Hello and welcome to the Recovery Channel. We're going to talk today about office-based buprenorphine therapy for opiate dependence. Now briefly, in 1918, approximately, the Harrison Act made it illegal for any doctor to treat an opiate addict with opiates. Actually, in the late 19th and early 20th century, doctors had a pretty good idea that they were dealing with a patient who had a brain-based illness, and if you treat them with appropriate doses of opiates, then you would stop their addictive behavior and their cravings. That was illegal for most of the 20th century until methadone was legalized for the treatment of opiate addicts. And now we have a new use for an old drug called buprenorphine, which has been around for a number of decades. But someone had the bright idea to say, maybe we can use a little bit safer way of suppressing cravings in opiate addicts. And lo and behold, that led to the Drug Addiction and Treatment Act of 2000 for office-based or hospital-based prescription. After getting a waiver, the doctors can now use this medication to suppress cravings in opiate addicts and allow them to live a much more normal life, free of cravings and use of heroin and other terribly addictive drugs. What this medication can do is substantially improve the tolerability of withdrawal and detoxification of opiate addicted patients, and then also be used as opiate agonist maintenance treatment to suppress cravings over a period of months or years in the recovering addict. In order to get this specific waiver from the Center for Substance Abuse Treatment and the Drug Enforcement Agency, physicians must complete at minimum an 8-hour training course to receive this waiver, and then they will receive a second DEA registration number beginning with an X instead of the usual ABC or other letter. The other other physicians that can get this are addiction medicine specialists who fulfill certain registrations, such as passing the American Society of Addiction Medicine certifying exam or the American Board of Addiction Medicine certifying examination. So again, briefly to recap, we have medications that can interact with mu-opioid receptors in the brain 3 different ways. One is a full agonist, such as morphine, such as methadone, such as hydrocodone or oxycodone. This fits into the mu-opioid receptor, activates it, and produces the full spectrum of opiate effects: pain relief, cough suppression, constipation, euphoria, and so forth. A partial agonist, such as Stadol, such as Nubain, or in this case, such as buprenorphine, fits into the opiate receptor incompletely, only partially activates the mu-opioid receptor with little or no euphoria, little or no other side effects other than production of physical dependence. And this is the desirable characteristic that buprenorphine brings to the table in treatment of opiate addiction. A full antagonist, such as naltrexone, blockades and does not activate the mu-opioid receptor, holds tightly to the mu receptor, and prevents other opiates from activating the mu-opioid receptor. In this short video, we look at partial agonist hitting the mu receptors. And again, if we look at these light green colored molecules, and this is the outside of a brain cell membrane, it comes in, partially activates, but otherwise blockades full opioid agonists and produces only a very small amount of stimulation of the mu-opioid receptors. These dark green molecules, such as heroin or morphine, would bring about a lot of electrical stimulation, but also releases dopamine into the system that brings about some mild stimulation as opiates do. So partial opioid agonists only bring about a very small amount of dopamine release with a very small reinforcing effect. Buprenorphine, again, is a very high affinity, meaning it holds on to very tightly, partial mu-opioid agonist, and is a weak kappa opioid antagonist in the brain. Now, one of the important parts about buprenorphine and allowing it to be prescribed in the doctor's office is the agonist effects plateau at higher doses and begins to actually reverse itself and act like an antagonist. This ceiling effect imparts safety, so we get very, very, very minimal respiratory depression even at very high doses, therefore making it a very safe type of opiate to give to patients who are taking buprenorphine. Much less risk of an overdose, much less physical dependence, and in fact, in one formulation that we'll talk about, naloxone, which is the life-saving drug that can be given by injection, is mixed in with the medication to prevent the diversion and abuse liability. Suboxone is buprenorphine plus the naloxone mixed in with it. So if this medication is injected, the naloxone will put the patient into immediate withdrawal. However, naloxone is not absorbed sublingually. It is destroyed in the mouth, therefore only the buprenorphine is absorbed. So buprenorphine is manufactured as sublingual tablets and now films containing either 2, 4, or 8 milligrams or 12 milligrams of buprenorphine with a 4-to-1 ratio of buprenorphine versus naloxone in them. Subutex is the brand name, actually is no longer produced anymore, but we have generic formulations that are sublingual formulations of buprenorphine only. In other words, this formulation does not have the abuse prevention drug naloxone mixed in it. Therefore, Subutex or pure buprenorphine should probably only be used in hospital settings rather than as maintenance therapy for patients as an outpatient. Detoxification uses usually around 4 to 16 milligrams per day, depending on the individual duration of use and number of milligrams per use. Usually given about twice a day as per the opioid withdrawal scores. Regular dosing around the clock every 12 hours with a fixed dose can be effective, but usually we can get by with a shorter duration of detoxification and fewer milligrams of buprenorphine if we use the opioid withdrawal scoring system. This again is the 8 milligram size of Suboxone. It has buprenorphine with naloxone. Subutex has buprenorphine only in it. Only about 30% of the dose is bioavailable in this formulation. It reaches peak plasma concentrations in between half and 2 hours and should have a duration of effect around 28 hours. It is placed under the tongue in a sublingual form, either as a tablet. This is a Subutex without buprenorphine, but this can be cooked down into a liquid formulation that then can be drawn up and injected without naloxone in it and still be abused. This is where Subutex gets its poor reputation. A newer formulation that I use almost exclusively now of Suboxone is the film. These are in child-proof, protective, numbered, and trackable film aluminum foil containers that have to be folded over and open, and therefore it has a high classification of child protectivity. And these are better tasting and more quickly absorbed than the tablets used to be. And these are also placed in the sublingual part of the mouth to be completely absorbed until the patient eats or drinks so they can get their full daily dose. They are available now in generic formulations, both buprenorphine with naloxone, 2 milligrams and a half milligram, or 8 milligrams and 2 milligrams, again the same 4-to-1 ratio of buprenorphine and naloxone, available in generic formulation now. This is a new branded generic called Zubsolv, which is still a 4-to-1 ratio but has a higher bioavailability. Therefore, instead of 2 milligrams, it's only 1.4. Instead of a half milligram of naloxone, 0.36 milligram. And the same, instead of 8 and 2, this is 5.7 and 1.4. However, because of increased bioavailability, more of the active ingredients absorbed, leading to exactly the same amount in the bloodstream after using either Suboxone or Zubsolv. Again, to equate these is 5.7 milligrams in Zubsolv, Suboxone tablets, 8 milligrams, Suboxone films. These are all bioequivalent as far as how much is absorbed into the bloodstream. Now, induction onto buprenorphine therapy is done usually in an office setting, sometimes a hospital setting, but usually in an office setting. And what we want to do is find the ideal maintenance dose of buprenorphine for that individual patient. The induction phase usually lasts about 2 or 3 days to be able to settle upon the regular daily dose that will not produce unwanted side effects but will effectively suppress cravings. And the ideal daily dose does that without untoward side effects. Patients who are addicted to short-acting opiates like heroin, like morphine, like oxycodone, we wait for the patients to be in mild to moderate withdrawal as dictated by the opioid withdrawal scoring system, usually a score at least of 6 or higher. And then we give the initial dose of 2 to 4 milligram with a maximum of the first day of 8 milligram to see if that's going to be their regular dose. A typical maintenance dose ends up being 12 to 16 milligrams per day. Either in once-a-day dosing, I find that most patients do better with a twice-a-day dosing, generally around 7 or 8 in the morning and around 4 or 5 in the evening. We rarely go up above 16 milligrams, occasionally to 20 milligrams, but I strongly recommend that only a very small percent of patients, if any, be given 24 milligrams per day or higher. Usually what you'll find is the patients have adequate saturation at 16 milligrams and the rest of the dose ends up being sold on the street. Patients who are dependent on longer acting opiates such as MX-Contin or methadone or OxyContin have a higher risk of precipitation of withdrawal because Suboxone, while it is a partial agonist, is a high affinity potent mu opioid partial agonist. Therefore, you want to reduce the methadone dose to no more than 40 milligrams a day and then proceed with induction with the patient in mild to moderate withdrawal. Again, the total daily dose should be, in vast majority of patients, no more than 12 to 16 milligrams. Occasionally 4 to 8 milligrams will be sufficient for an average size adult, but 12 to 16 milligrams is a very common dose range for maintenance. But never go over 32 milligrams a day. That's the absolute ceiling, but rarely will patients need 24 milligrams or more per day. Usually, like I said, the extra doses end up being sold on the street. This diagram shows that at 16 milligrams, these opioid receptors, which are lighter in color, are virtually fully saturated at 16 milligrams. More than 96% of all opioid receptors are saturated in the brain at 16 milligrams, and you get very little extra saturation of opiate receptors at that 32 milligram dose. So there's very rarely a reason to go up above 16 milligrams per day, unless the patient is really interested in making some money on the street. And we can see here on 16 milligrams a day, we have progressively fewer and fewer opiate positive drug screens until we get to about 16 milligrams per day. Now, retention and treatment at 6 months. Heroin patients, prescription opiates, mixed opiates, we have a very high retention rate of patients who take buprenorphine. These are usually very well accepted by patients, and a very substantial number will complete treatment. These numbers are very high, as opposed to the less than 20% of patients before buprenorphine who are retained in treatment. Effectiveness of length of treatment, we have a substantial improvement in patients who are very effectively treated, especially if we keep them on maintenance therapy more than a month. Minimal effect at 7 days of maintenance, some effect at 30 days, but we get the optimal treatment of our patients if they are maintained at an adequate dose of buprenorphine for longer than a month. Personally, I never start a patient on maintenance therapy for buprenorphine for less than 6 months. And I tell them that. We are not going to discuss discontinuation of this medication until you have completed treatment and been clean and sober for no less than 6 months. That takes it off the table for discussion and usually gives people some relaxation. Okay, at least I'm going to have this craving relief for at least 6 months or so. Crime, drug dealing, prescription fraud goes down dramatically on patients who are maintained on opiate agonist therapy. So we're benefiting society as well as the individual therapy. And we have patients who are substantially, increasingly employed full-time and less unemployment when we use Suboxone. We're helping families stay intact. We're helping people get back their self-respect by producing adequate work and bringing home the bacon to their families. Now, what is an ideal patient that we need to consider for buprenorphine maintenance therapy? Patients who are actively seeking treatment and they definitely want off illicit opioids. This is not someone who's saying, all I want is detox and I'm going to go back and start using it again once my tolerance goes up. We want patients to be committed for sustained recovery. Patients who are opioid dependent and are not using other active substances. In other words, I only want to stop my heroin, but I'm going to keep drinking, using marijuana, cocaine, and methamphetamine. We probably should look at some other form of treatment other than buprenorphine. In other words, we don't want to just select out a wedge of opiate addiction and have them continue using actively their other drugs. No unstable hepatitis, because buprenorphine is metabolized through the liver. If we get an okay from a hepatologist or gastroenterologist who is monitoring active hepatitis B or C and they say it's at adequate levels to maintain the patient on buprenorphine, then that's fine. And no untreated major psychiatric disorders, because that will really interfere with patients being compliant with their regular dose of medications. Liver enzymes less than 3 times normal level is a general rule of thumb. If they have some mild elevation from some type of liver injury, but less than 3 times normal level, then buprenorphine is safe. We want patients who are willing to persevere with addiction treatment. Not, I'll try it for a couple of weeks, but I'm not going to go to treatment for beyond a couple of weeks. I mean, I got to get back to work. These are probably not good candidates for buprenorphine therapy. They must be able to understand and follow directions, must have manageable environmental stressors, okay? The goal is to suppress withdrawal symptoms. The goal is to eliminate or at least minimize craving for opiates. And if patients do use opiates, to not allow them to get the positive reinforcement from an injection of heroin or perk 30 by reducing the euphoric effects by blockade of the mu-opioid receptors, and to improve functional status in all spheres of life, family life, employment, legal, and so forth. The rationale for using a safe medication such as buprenorphine is that it is cross-tolerant to other opiates. Obviously, we do not detoxify heroin addicts with heroin. We don't detoxify OxyContin patients with OxyContin. We use a safer, easier, more manageable, less euphorogenic compounds such as buprenorphine to prevent withdrawal symptoms and relieve cravings for opiates, and also, again, as I said, to block the euphoric effects of other ingested opiates. The goal, of course, is no relapse, but opiate addicts frequently relapse, and we want to minimize the positive reinforcement from using opiates. When we initially evaluate a patient, we don't just talk with them briefly. We have to do a complete medical history and physical examination, a complete and thorough substance use history, co-occurring eating disorders, gambling disorders, use of alcohol, marijuana, or other licit or illicit drugs, a complete full mental status examination, a full diagnostic criteria must be met for the diagnosis of opiate dependence. We do not use buprenorphine maintenance therapy on patients who are simply misusing or occasionally binging on or only abusing opiates. We want the verification of opiate addiction, opiate dependence, or in the new DSM-5, opiate use disorder, moderate or severe. These criteria are a problematic pattern of opiate use over a 12-month period. Their opiates are taken in larger amounts over a longer period than was intended. Persistent desire and unsuccessful efforts to cut down and control opiate use. Great deal of time is spent obtaining, using, and experiencing the effects of opiates. Cravings, which is new in the DSM-5 and is very important, a strong urge or desire to use opiates. Recurrent opiate use interfering with major life events such as work, school, and home events. Continued use of opiates despite knowing that it's caused by opiates. Important social, occupational, recreational activities are not completed because of opiate use, and recurrent use of opiates in situations in which it is physically hazardous. Continued use of opiates despite having a persistent desire to cut down or quit, and having adverse consequences. In addition to that, we have physical diagnostic criteria such as tolerance, which is an increased amount of opiate needed for intoxication or the desired effect, or if the dose of opiates is constant, then we have a markedly diminished effect because of tolerance. In addition to that, we have physical withdrawal symptoms that are caused by cessation or cut down of use, or other opiates or related substance are used to ameliorate and avoid withdrawal symptoms. If we have 2 or 3 of the above symptoms, then we have mild opiate use disorder, moderate or severe, or 4 or more symptoms. And we have to fulfill this criteria before we want to consider opiate agonist therapy. Laboratory evaluation is important. We need to check liver function tests because buprenorphine is metabolized through the liver. We want to check a pregnancy test to make sure the individual is not pregnant, or if they are pregnant, that does not eliminate them as candidates for buprenorphine therapy, but we must obviously refer these patients for good prenatal care. We want a toxicology screen, most commonly urine, specifically looking for opiates, but other drugs of addiction, to make sure we've confirmed that the patient is using opiates and not using other stimulants, alcohol, marijuana, or other addictive drugs. We can do that with a breathalyzer, hair screen, but urine, of course, is the most common toxicology screening that we have. We can check with, in Ohio, the ORS report, the Ohio prescription reporting system, or other online state prescription databases to see if the patients are obtaining buprenorphine or other drugs from other providers. We want to maintain an up-to-date list of all over-the-counter and prescription medications taken by the patient. We want to know if the patient's taking benzodiazepines. We want to know if they're taking over-the-counter alcohol-containing or stimulant-containing products. And we have to check with the patient every visit to find out if we have an up-to-date database of their over-the-counter prescription medications. And also a signed release allowing us to contact other behavioral health and medical providers, as well as the pharmacies used by the patient, to make sure the patient is being compliant with our rules and regulations. A treatment plan must be produced. It's not simply stop using opiates. What treatment requirements are going to be part of the contract? Inpatient treatment, residential treatment, outpatient treatment, intensive outpatient treatment, 12-step meeting attendance. All these need to be carefully explained and checked on. Therefore, we need releases to check with treatment providers. Sometimes a release of information to talk to an AA sponsor can be very important for those who are in the phase where they're simply attending 12-step meetings, but also have ongoing opiate agonist therapy. What is the goal of treatment? Is it complete and total abstinence from all mind and mood-altering chemicals? That should be the goal, and that should be clearly explained to the individual that marijuana use, alcohol use is not going to be tolerated. We should counsel the patient but not have tobacco cessation an initial part, since about 85% of opiate addicts also use tobacco, but taking every opportunity to encourage the patient to stop using tobacco should be part of the treatment plan as well. What are we going to require? Completion of outpatient treatment, 12-step meeting attendance. Again, how many? It should be no less than 3 meetings per week, at least for the first year of recovery. And are we going to assign a minimum duration of therapy? Like I said, I tell all my patients we're not going to discuss discontinuation for 6 months to make sure you're solidly in recovery before we take away that medication or even discuss it. Daily dosing is very convenient for patient. Twice-a-day dosing, I find that most patients get by with. Very frequently, patients can get by on a lower dose if they split it twice a day as opposed to taking the full dose. But taking the full dose in the morning is a perfectly acceptable method of dosing. After the first dose, patients should be followed up in a few days, then weekly, then in 2 weeks, and then monthly thereafter once a stable dosing regimen is established. I recommend that all patients return their empty film packets. They should be periodically called in for random counting to make sure that they're not selling them on the street. And any drug screens that are obtained, which should be done regularly, should be witnessed. An unwitnessed drug screen is not reliable. You can buy products over the internet, such as the urinator, that look very much like a penis, or the penis can be overlaid on top of this tube, and we have to actually watch the urine come out of the urethral meatus. Patients can also buy clean urine that will be substituted in the bathroom if the urine production is not witnessed. So we have to have a same-sex individual witness the urine drug screen, or it's not really reliable. Coordination should be obtained between the prescribing physician and other treatment providers. We should not simply be the prescription writer. We need to be part of a comprehensive treatment team that includes chemical dependency counselors, that includes psychologists or social workers or any other members of the treatment team, to be a part of a total support network to get people engaged in treatment and complete treatment. Missing monthly follow-up visits obviously is a question that we have to term non-compliant. People who say that they lost or had stolen buprenorphine doses, I never replace these without either verification from a reliable individual and or a police report. Inappropriate over-the-counter prescription medications. Well, my doctor said I really needed my Xanax, and the emergency doctor said I really had to take these Percocets 3 times a day. All prescriptions should be verified and okayed by the Suboxone, by the buprenorphine prescribing physician prior to the patient filling them. As we all know, most physicians do not understand the disease of addiction and do not understand the concept of cross-addiction. Patients who fail to complete treatment, including 12-step meeting attendance, and fail to provide their empty prescription packets and bottles should be considered non-compliant, and sanctions need to be in place up to and including tapering the patients off of medication for failure to comply. Positive drug screens for other addictive drugs, including alcohol, which means that we should not be screening for alcohol, we should be screening for ethyl glucuronide and ethyl sulfide, metabolites of alcohol, must be addressed specifically with patient. Every provider must have their own criteria for either counseling, return to treatment, or discontinuation of buprenorphine prescriptions for continued use of alcohol or other addictive drugs. And we have to constantly determine if these individuals have a desire for complete abstinence from all addictive drugs. That has to be part of the treatment plan. Urine drug screens that are considered positive, again, are non-compliance. Ethyl glucuronide and ethyl sulfide are currently considered the standards of choice for checking negative use of alcohol. A blood screen called the carbohydrate deficient transferrin may also periodically be used for patients who you believe might be drinking. These are reported as a percentage. Liver enzymes or mean corpuscular volume are also methods to check for continued use of alcohol by patients on buprenorphine therapy. If a drug screen is negative for buprenorphine and you question as to whether the patient actually is taking their buprenorphine or selling it on the street, you can send the same specimen to the lab saying you want a no minimum level. In other words, I don't care if it's up to your threshold, I want to know if there's any buprenorphine in this urine or not. And if that comes back as negative, you really have to question as to whether the patient is selling their buprenorphine on the street. While we're talking about diversion on the street, this is not the serious nature of diversion, such as prescribed OxyContin and Percocet. Patients do not use Suboxone or Zubsolv or other forms of buprenorphine to get high on usually. It is used if the individual runs out of their heroin or other drug of choice to stop their withdrawal symptoms until they get in for their next drug dealing dose. Now, while this is not optimal, if a patient uses a sublingual buprenorphine to stop their withdrawals instead of stealing from a bank or a 7-Eleven or hitting someone over the head to steal a purse to get money for heroin, it probably shouldn't be considered as severe as having hundreds of milligrams of OxyContin. But still, illegal diversion is not optimal for any controlled drug whatsoever. Now, what we want to do is document on our follow-up visits that the patient reports abstinence from banned substance, including alcohol. Urine drug screen results should be reviewed and initialed by the patient to make sure that they understand that they have a negative drug screen. And if it turns positive again, it's not from drugs leaching out of their system. It's because that we know that they've used drugs. We want to make sure that they're compliant with all of the treatment recommendations and that we have a signed release so we can verify that they're showing up for treatment, that they're completing treatment, and if we need to, speak with their other prescribing physicians to know that they are not being prescribed drugs that are on our ban list, such as benzodiazepines and other opiates. We should continually review pharmacy records either by calling the pharmacy or checking the state database, and also review our treatment plan progress. Rather than being open-ended, we should periodically discuss a patient whether they believe they're ready to taper off their medication. Some people will say, I think I've been sober for a year or so, maybe we can talk about it, or Doc, my life is going so great, I don't want to talk about it, let's talk about it in a few months. Either of those are good acceptable answers. Criteria for discharge from office-based opioid treatment could be continued positive drug screens for illegal drugs, non-prescribed mood-altering drugs obtained off the street, or unacceptable prescription drugs such as stimulants or benzodiazepines. I do not allow my patients to take stimulants for adult-onset ADD. I do not allow my patients to smoke marijuana. I do not allow my patients to take benzodiazepine drugs. I know of no patient that was born with a chronic benzodiazepine deficiency. There are acceptable alternative substitutes for all of these medications that are not addictive drugs. Self-adjustment of medication dose beyond the first week should not be tolerated. Well, Doc, I was in a bad state, so I took an extra couple, so I ran out soon. That is not acceptable treatment. That should be discussed with the physician or someone in your office before the patient self-adjusts their dose. And continued failure to comply with complete treatment recommendations should bring about a strong consideration for discharge from OBOT treatment. Now, what about treatment of pregnant women? Some physicians believe that the optimal treatment of choice would be detoxification from a heroin or other opiate-addicted mother. But in actual fact, that is harder on an infant because almost certainly that patient will not stay sober. So currently, treatment of choice for a pregnant patient who is willing to follow up with treatment is opioid agonist therapy, either methadone or buprenorphine. Methadone for years has been the drug of choice. There are a lot of studies now that show buprenorphine is a perfectly acceptable medication that has less physiological suppression of the fetal heart rate with a less clinically significant and severe abstinence syndrome after birth with buprenorphine as opposed to methadone. Buprenorphine is compatible with breastfeeding. It is not passed on to the infant while breastfeeding, and there is no documentation of any deleterious effects in utero from buprenorphine exposure on infant development. So this should be considered along with methadone as a part of a comprehensive treatment approach for opiate-dependent pregnant women. Now, what about the cost of these medications? Naltrexone tablets, probably the cheapest option we have next to methadone, but have a very poor compliance rate. Vivitrol injectable buprenorphine, very expensive medication, however, is covered by most insurance and most Medicaid products, at least in Ohio, and frequently can be obtained one way or another for patients who need it. Suboxone, or generic buprenorphine, or Zubsolv, is becoming very, very affordable. Roughly $1 a milligram, or $240 to $480 per month. Now with competition from branded Zubsolv or with generic buprenorphine tablets, the price of this is rapidly falling as generics have a tendency to do. Methadone itself is a very inexpensive drug itself, but visits to the methadone clinic every 2 or 3 days can really add up. How long do we maintain patients? This is always a key question of patients, family members, and other providers. Just like high blood pressure medication, just like inhalers for asthma or emphysema, a chronic treatment is best for a chronic disease. So what we do is continue the patient on buprenorphine therapy as long as the patient continues to benefit from treatment, as long as the patient is at risk for relapse, as long as there are no serious or unacceptable side effects, and very importantly, as long as the clinician believes the patient will be maintained. There is no number of months or years that is built into treatment. There are patients who have been on methadone therapy for decades, having productive lives, including physicians. And there's no reason why there should be an arbitrary or artificial limit set on duration of therapy for opiate-addicted patients using sublingual buprenorphine. Now, what about tapering buprenorphine when their vote is 2-0? In other words, the clinician and the patient both believe it's time to taper therapy. When the patient has completed recommended treatment and is in successful long-term recovery. Long-term can be defined as 6 months. I prefer long-term be defined as no less than a year and preferably 2 years. The patient is regularly attending 12-step meetings and has a commitment to continue attending meetings. The patient has not experienced drug cravings of any significance in the recent past. And the patient preferably is in a stable relationship situation, home situation, and employment situation. We strongly emphasize the word slow as far as tapering is concerned. Again, there's no number of weeks or months. It will be very dependent on the individual and how quickly they're willing and how much side effects they have. I generally take no less than 2 to 3 months for the average patient to decrease off of a 12 to 16 milligram dose, and I usually will rarely take away more than 4 milligrams and preferably 2 milligrams, let them equilibrate for 2 to 4 weeks before we take off another 2 to 4 milligrams. So again, taking 2 to 3 months to taper is not only acceptable, but is preferable to a more rapid therapy. In review, methadone and buprenorphine are the only opiate agonists approved by the FDA for treatment of opiate addiction. Levocetamol, Orlam, or LAM are now off the market, so we have methadone and buprenorphine only. And the best evidence does support maintenance therapy. This is a highly relapsing illness. Short-term detoxification and taper is not effective in the majority of patients with opiate addiction, and maintenance therapy should be strongly considered in any patient with a significant duration of opiate addiction, especially heroin addiction. Anytime patients are tapered off and this medication is discontinued, a reinstitution of maintenance therapy should be available as backup in case relapse occurs. And when detoxification is chosen and quote-unquote drug-free treatment is considered, we should always have buprenorphine or other opiate agonist therapy, such as methadone, available in case that occurs. At a later time, we'll have an open forum available for questions. Right now, we'll close, and thank you for your attention to this important lecture on office-based opiate agonist treatment of opiate addiction. Thank you.